Betrayal is often unintentional. It doesn't mean that people get up in the morning planning to hurt somebody on the other side of this equation. It's unintentional. I made a decision that was based on incomplete information. I did not project the consequences of that. So the response to it, when somebody stands up and says, "Ooh, hey, this doesn't hit right with me," is not to get defensive, but to say, "Tell me more. Let's talk this through. How can we come to a mutually agreeable solution that allows your moral obligations to remain intact?"
This is the Visible Voices podcast. I'm your host, Dr. Resa E. Lewis. In today's episode, I speak with Dr. Wendy Dean. Wendy is a physician, a psychiatrist by training, an author, a podcaster, and a co-founder of The Moral Injury of Healthcare. This is an organization that addresses systemic causes of moral injury among healthcare workers. Her podcasts are entitled Moral Matters, and more recently, she's the co-host of 43 cc's. She is the author of If I Betray These Words, Moral Injury in Medicine and Why It's So Hard for Clinicians to Put Patients First. She's also the first author of a recent New England Journal of Medicine article entitled Moral Injury and the Global Health Workforce Crisis: Insights from an International Partnership. When we get to the episode, I'm speaking with Wendy about her different hats, what she wears, and what she's learned from podcasting. You have a few hats you wear, including physician, podcaster, author, entrepreneur, starter of an LLC, equestrian, and more. Let's start with podcasting. You've been on both sides of the microphone. What would you say you have learned as a podcaster that informs your work in moral injury?
Oh, storytelling, audio storytelling. So in my writing, I got pretty clear at how to write to the story. But when you're podcasting, you really have to be paying attention to not only the words you're saying, but the cadence and your enthusiasm, and also who's out in the audience that you might not have captured otherwise. Why do they want to listen to this? What does it matter to them? And it really is a very in the moment sort of empathic exercise in who's out there who may be listening.
To that end, is there a specific something that you make sure you do so that it is effective as a spoken story versus a written story?
I think what I try to do is keep in mind the different potential audiences that are out there. So you and I think, are very comfortable talking to clinicians because that's who we are. That's where we come from. So that's like falling off a log for us. But also keeping in mind that there may be administrators listening who are looking for ideas of how to help the people that work for them in their workforces. And also, what is it like to be a patient in this system? I've seen it from all three different angles. And so bringing in each of those elements of that part of the story, it can be really helpful.
The concept of moral injury is not burnout. It's not new. It's pretty much spread around this country. However, it's not just limited to the United States. It seems the concept of moral injury has gone global. And in fact, you and co-authors demonstrated that in a recent New England Journal of Medicine piece. Can you tell the listeners more about that?
6 years ago when we started this, we thought that it was a phenomenon that arose out of the corporatization of healthcare that we're seeing, the consolidation, the vertical integration, the profiteering. And what we started hearing was from other countries like the UK and France and Germany and Australia, New Zealand. These are countries with public health systems. So why were they struggling? And it turns out that if you take it one step back, if you go up 10,000 more feet, it's not about the corporatization of care necessarily. That's one of the drivers. But it's about the structural determinants of health. How do we decide how to distribute resources in our societies, and who gets to decide? And then who has to carry that out? For example, in publicly funded systems, there may be really well-intended legislators who have done their level best to make good decisions about the healthcare resources, but they just don't know because they're not clinicians. And so they make decisions that clinicians then have to carry out that they say, oh, hang on, this is not the choice that I would have made. And so that for us is where the moral injury starts coming in. You know, I know what my patients need, and for whatever reason, my hands are tied and I can't get them what they need.
So, specifically within this New England Journal of Medicine article piece, you describe the difference between burnout, moral injury. You say this is not just a US phenomenon, this is a worldwide, global healthcare system phenomenon. And what solutions do you put forth?
I mean, I think the first thing that we need to do is agree that moral injury is a separate issue from burnout. So I think a lot of the resistance in the US has been that why are we changing happy to glad? We have burnout. We've talked about it. We've assessed it and addressed it for half a century now. Why do we all of a sudden need to change it to moral injury? And in fact, it's not just changing the language, it's really two separate experiences. It's like saying we're short of breath, but it's because we have not just pneumonia, we also have bronchospasm with it. They're two separate mechanisms that are happening. So that's the first thing that we need to do. And then we need to acknowledge that that's an issue for our healthcare workforces. And we need to start making some research inroads into what the real drivers are and therefore what might help us solve it. But I also think we need to recognize that really at the root of moral injury is a values misalignment. And if that's the case, then what we need to do is start having those conversations about shared values and realigning those values.
I resonate a lot with what you shared about research. Where do you know that quality research is being done on moral injury right now?
There are a lot of different places that are doing some of the research, but it's mostly been on because okay, let's let's just keep in mind it's really been talked about for 6 years. That's a minute, right? Burnout we've been looking at for half a century as I said. So what we have been primarily focused on is kind of characterizing what moral injury is, trying to understand what the prevalence is, right? Just describing this phenomenon. So now, with one of our collaborators in the UK, we're starting to look more for empirical data. What is this? Okay, so let's really get to the heart of it. Let's prove that this is something real. And then once we know what the drivers are behind it, we can start creating some solutions. So, for example, we have about a year ago, a little over a year ago, we talked to 50 moral injury experts around the world and said, if you were going to create a non-morally injurious organization, what would that look like? And they gave us 113 different recommendations. So there's data out there. We just need funding to be able to capture it, to be able to continue doing the work, and we need clear definitions.
Number one, I really like this distinction of this isn't happy to glad, but taking this concept of definitions and understanding distinctions and nuance further. Someone recently said to me that rather than calling it moral injury, they heard that people are now beginning to call it ethical injury. And I'm wondering your reaction to reframing this as ethical injury and what would be the difference for listeners who are still trying to get their heads around the concepts, but why definitively what we should be speaking about is moral injury.
So I think there's a clear definition of moral injury. There's scholarship for the past 30 years about moral injury in the military. It is an uncomfortable topic. And I think people want to soften that concept by giving it a different name and maybe massaging the definition of it. But the truth is that these are hard things that we're up against. It's an intrusion in our moral ethical obligations to our patients. So I would love to see that reference or talk to people who are questioning it, because I do think that moral injury is really an accurate term. I think a lot of people kind of wince at the concept that it comes from betrayal, right? But betrayal is often unintentional. It doesn't mean that people get up in the morning planning to hurt somebody on the other side of this equation, right? It's unintentional. I made a decision that was based on incomplete information. I did not project the consequences of that. So the response to it, when somebody stands up and says, "Whoa, hey, this doesn't hit right with me," is not to get defensive, but to say, "Tell me more.
Mm.
Say more words. Let's talk this through. How can we come to a mutually agreeable solution that allows your moral obligations to remain intact?"
In your book, If I Betray These Words, Moral Injury in Medicine and Why It's So Hard for Clinicians to Put Patients First, you profile clinicians across the country who are tough, resourceful, and resilient, but they feel trapped between the patient-first values of their Hippocratic Oath and the business imperatives of a broken healthcare system, i.e., the essence of moral injury in healthcare. So, for some non-healthcare, non-doctor listeners, what does this look like? Can you give an example, not from the book, but from your own practice, or maybe something you recently experienced yourself or with a family member?
Folks can listen to the 43cc podcast and get at least one example every single episode. My co-host is a practicing orthopedic surgeon who lives this every day. So it can be as simple as when he goes into the exam room, takes him 5 minutes to figure out that somebody may have a rotator cuff tear. And then, depending on their insurance, he may know that they need to go to the OR, but first they have to go to 6 weeks of therapy, and then they have to wait another 3 weeks for their MRI. And each step of the way, both the patients and he need to jump through hoops. And there may not be any decrement in their outcome, but there may be, right? So that's a very easy example that I bet every single patient can relate to.
Yeah. Is there one that you've had when you were in clinical practice or something you experienced on the patient side?
It was very similar. When I was calling insurers to hospitalize a patient, and they would say, well, it doesn't really sound to me like they're that suicidal, like they're that committed.
Meaning committed to killing
Committed to
themselves.
the action.
Yeah.
Right. And I'm the one sitting with the education, the training, face to face with the patient, having gotten the look and the feel and the words, putting it all together. And somebody who is somewhere, who knows how far away, who's never seen the patient, who I don't even know what their background is deciding whether or not that patient is at risk enough.
In anticipating asking you that question, I thought about my own experience in the emergency department. I thought about the too numerous to count patients that came with dental pain, anything from as early on as just a cavity that hurts or a deep, deep dental infection where their face is swollen, they cannot open and close their mouth. And it's because they don't have dental insurance, don't have access to a dentist. Even when they do show up at the dental clinic, there's a 6-week wait. And there is this injury of the dismissal of their pain, the dismissal of them not supposedly trying to seek the care for their infected tooth, which is not at all the case. The kind of blaming the victim. Also working and seeing that certain patients are rushed ahead and rushed in because of their insurance status or the color of their skin versus other people that are allowed to wait a little bit longer. And it just weighs and it doesn't feel good.
Yeah. And, one of the things that you're pointing out is one of the challenges in moral injury is when does it become a moral injury? So what you're pointing out is that sort of death by 1,000 cuts, where it's not one big egregious event, it's multiple smaller events over time, because the definition of moral injury is betrayal by a legitimate authority in a high stakes situation. And so in this case, who is the authority? It could be the insurer, it could be society as a whole. The high stakes situation may not be right now, but it may be the delay that causes the endocarditis. I think this is where moral injury sort of departs a bit from its military counterpart, but that doesn't mean that it doesn't exist.
Wendy, for people that haven't read the book, haven't picked up the book and thumbed through it, can you give us a brief outline of how you designed it, what they will see when they read the book?
It is a series of stories that take different drivers of moral injury, and they take a clinician who faced it, tell their whole story, and then it talks about what that driver is, and not only what it is and where we are now, how did we get here? What's the history behind this? Because what I wanted to do was to give people the blueprint they needed to know where we've been so we know how we can change the system that we have. And so the first half of the book is really clinicians who are facing moral injury and who may or may not have any sort of way out. And the second half of the book was really to say, okay, these solutions aren't perfect, but these are folks who have found a way forward or have found a way out.
How are you different having written this book?
I'm older. I'm grayer. I may have pulled out some of my hair. So, first of all, writing a book was never on my bucket list, but we can thank Sam Shem from the house of God for being persistent and insisting that we write this book. It restructured how I think about what we do in healthcare. And I don't mean in a big way, but what I mean is we can tell stories. Like what we do every day, we are storytellers every day. When you write a soap note, that's a story. It's the subjective, which is what the patient says was going on. So that's like the meat of it. That's the hook. And then the objective is, what's the data that backs this up? The assessment is, so how do we put this all together? And the plan is, so what are we going to do about it? I mean, I just wrote an 80,000 word soap note. That's all. And it made me think harder about what my experience of healthcare was, which was not always a good thing.
Yeah.
It was rough writing a book.
You've been on many podcasts discussing moral injury, discussing the book, interviewed as well, radio, television, etc. Is there a question that you've been dying to answer or you really have wished that someone would ask you?
The one consistent thing that I think people forget about is that we talked about this not just being a US thing, it's also not just a clinician thing. So we're really clear that this is not just about physicians. I wrote about physicians because that's what I know. But as soon as our first article was out in 2018, we heard from respiratory therapists, social workers, physical therapists, nurses, the whole gamut of healthcare. We also heard from veterinarians, educators, and public defenders, by the way. So we know that it's clinicians. It is also about administrators. So we did a study that showed that both administrators and managers during COVID, about 40% of them experienced moral injury. They knew what their workforce needed and they couldn't get it for them. And so what that says to me is we have a point of commonality. If we can get to that place and we can work from there, recognizing that we both have common experience, I think we're going to be much more able to get to solutions more quickly.
I think listeners are not surprised at the broad base of workplace professionals that experience this and resonate with this and from whom you've heard. And I think for anybody that's wondering what it feels like, it feels horrible. It feels horrible. You feel helpless. And I read a very prescient, I wanted to use that word right there, prescient op-ed written by our friend Daniel Ofri, and you have spoken about this same op-ed that I read, and my life sort of changed the way I looked at healthcare, and you have talked about this. She wrote an op-ed in the New York Times that basically, my summary, described the healthcare system as sadistic, and we, as workers in the healthcare system, I'll say in this case, clinicians, physicians, are masochistic. Now, I've brought this up before, and some people are like, Resa, I'm not a masochist. I'm like, no. I'm not necessarily saying that we're masochists. However, we have signed up for a role in a sadistic system for us to comply, for us to do all the work asked of us. There is a masochistic element to us or to the work we're being asked to do. What do you think?
I see it a little bit differently. The article was, I think, from 2019, and it was the business of healthcare depends on exploiting doctors and nurses. And I think masochism, I view as a very intentional act. It's not always, but what I think of is that we've never been taught how to construct flexible boundaries. So what we're educated and trained to is the patient always comes first, regardless, that there is no situation in which you can put your own needs before your patient's. And I think, on the other hand, what her article presumes is that, and I think she says this specifically, that administrators aren't doing this intentionally, right? They're not scheming to take advantage of the workforce, but the workforce also doesn't put up any resistance. We don't say, hey, this is unreasonable. This is unsafe for our patients. This has to stop. And so I think what I read it as is a call for us to start getting louder in the conversation and to say, on behalf of my patients, for their safety and the sustainability of my working life, I need to put up some checks and some stops.
Perhaps become a visible voice. Wendy, when did you realize you had a voice and when did you start using that voice?
Oh boy, pretty young. But I think I lost it. I also lost it sometime late in high school, college, medical school, residency. I think it is easy to subsume that voice to the structure that's around you. And I think when I got into my residency and I did a year of research, I started writing a lot more. I started exploring cutting edge technology. I was doing research on virtual reality in 1993. And so when I started getting outside of that typical bubble, I started thinking, oh, this is really interesting. Like I could have influence here.
And then you said you sort of went quiet or your voice went away / was always there. It came back through writing. Would that be accurate?
I mean, I think it was two things. It was partly through writing because I did a fair bit of writing in my research year, but it was also having my mentor that year who, for good or bad, sort of put me at the front of the room and said, I can't do this talk in Michigan. Can you go do it for me? I can't do this talk in New Orleans. Can you go do it for me? And realizing that there were ways that I could have influence that were different than the one-on-one interactions in an exam room.
100%. And to that end, with the work, subject matter expertise, writing and speaking about moral injury, are there aspects of your voice that have basically become brighter, louder, more bold-faced, or have pivoted a little bit because of the needs to explain to the community?
Gosh, the stuff that I do now, writing books, being on a podcast, none of that is anything that I imagined that I would do. But the first podcast we started was in October of 2020. And we did it because people needed support. They needed to feel seen. They needed to feel heard. And they could not read one more letter. Like, not one more letter in one more sentence, because they were trying to keep up with the science of COVID. So we started the podcast in October, and it's such a different way to communicate with folks. And it can be very storytelling, very journalistic, and that hits all my buttons.
You and I have Venn diagram overlaps in many ways. One I'll say is this podcast started March 2020. Similar reason. I felt like there was a need. And one of my first episodes was what was happening in different cities around the world regarding COVID. Geneva, London, Philadelphia. Followed soon thereafter of the role of ultrasound in helping to make a quicker diagnosis of COVID, because at that time we were sending tests away and it took hours to get that test back. And it was distressing. Another thing I'll share is this concept of storytelling and really realizing that we as physicians are storytellers. And I would say specifically with your training in psychiatry and work in the emergency department, my work in the emergency department, I think a lot of our colleagues don't make that realization that we are the recipients of stories. And we actually get quite good at, as you already described, the collation, putting it down neatly in a paper chart when you and I first started, electronic health record now, but also then we have to speak with someone, the consultant, the admitting team, the primary care doctor, a family member, and we make a nice, neat package of a story and can deliver it that's very comprehensible to everybody.
Yeah, I mean, I think the one difference is that in our training, we are taught to keep ourselves out of it. And for a story to really connect with your listener, with your reader, you have to bring yourself into it. And that was probably the thing that came closest to undoing me writing the book. Boy, that was hard. That was really, really hard.
I love that share so much because you have just identified one of my own challenges with writing. You know, I can easily tell, but people that give me feedback and edit my work say, Resa, where are you? Or all of a sudden they'll say, actually, when you speak, when you talk to me or do a podcast episode, you're in it. But when you write, all of a sudden you go away. They don't say it exactly like that. And I think I never realized that it was actually kind of trained and taught out of us.
Oh, it's protective too. So another funny story about writing the book, in late October, early November, I had gotten broken by my new horse, and my editor, we had finished about 8 chapters, and I was like, okay, good. This breakage is not really going to interfere with that very much. I'll be able to, because it was my dominant hand. About 3 days after I got broken, my editor called and she's like, I think we need to go in a different direction with the book.
Oh no.
She did. And she was completely right. But she said, I think we need to bring you more into it. I think we need to talk about this other aspect of it a little bit more. And I was like, wow. That was a rough week.
It's almost as if you anticipated my question, and I'm hoping that no one has pointed this out. Your author picture, your headshot, shows you wearing a right upper extremity, a right hand wrist splint. And I was
Mhm.
going to ask you why, what happened, and also that was clearly intentional to keep that picture in.
Yeah. So, okay, another funny story. So, I was going to be in the alumni magazine for Smith College, where I went to college, and it had been in the works for a couple of months. And they said, "We'll let you know when we're going to run it." They called me 2 days after my horse broke me. I had a shattered wrist. I had a torn hamstring, like entirely torn, and I had a fractured tibial plateau. And they're like, "Hey, would next Friday be a good day to come out and take pictures?"
Oh my goodness.
And I was like, "Well, I don't know, maybe I can walk." So I was literally, I think, 9 days out from my horse wrecking me in that picture. And what I wanted it to convey was not just that I'm a physician, but, I've been on the other side. The family member of a patient who is critically ill. I've been a patient myself more times than I like to count. So yeah.
You are the co-founder of a 501c3 entitled Moral Injury in Healthcare. Can you give sort of the 2-minute elevator pitch to the listeners about it, and how have you moved the needle already?
Yeah. So Moral Injury for Healthcare was an organization, a nonprofit that we set up in September of 2018, literally 6 weeks after our first article dropped, because we kept waiting for things to fade and it didn't. It kept building. So we're like, we need to do something with this. And so we set up the nonprofit to organize all of this energy. And we wanted to define this new experience, but then we wanted to make sure that we kept the focus on solutions. Like, okay, great. So now we all recognize that there is this new language. Now let's do something about it. And so what we have done with that is really to raise awareness. And the first 2 or 3 years was really about raising awareness and educating people. In the last 2 to 3 years, we have shifted to developing empirical data and beginning to look at solutions. I think if we want to talk about moving the needle, the fact that you and I are talking about moral injury, the fact that anybody knows about it, the fact that the Surgeon General talks about it, that's moving the needle. My previous work between having a psychiatry practice and doing this work was working for the US Army, developing novel technologies, innovative technologies. And when you look at the hype cycle, the curve for technology adoption, it is a generation long. The very fact that we have moved so fast with this language and this concept, I think is really remarkable. It's only been 6 years and we're already talking about solutions.
What's one thing that, like, I think I have something that is my moral injury equivalent, something that just I've noticed, I want to write about it, I want to speak about it, I want to get it out there. What's one thing you would recommend to someone that has this kernel and they're waiting for it to pop?
The first thing that we did was to do a deep dive, to do all the research that you could possibly do. What is this thing? What does it mean? What does it look like? Who else is experiencing it? And then to start carving it out and talking to people around you. Am I onto something or am I completely wet? And that way, not only does it help you understand if there's really sort of a market or a need for your new idea, but it helps you shape the idea. And I particularly looked for people who were skeptical because it takes a lot of energy to do this, like
Yeah.
a huge amount of energy. And if there's somebody already doing it, or if there's not a need for it, probably want to put your energy somewhere else.
For audience members that want to support you, support your work, the 501c3 and moral injury, what can they do to support you?
Yeah. So the great news about a 501c3 is it's a tax deductible donation. So if you go to the website, which is fixmoralinjury.org, you can go to the donate button. That helps us a ton. If you want to connect with us there, you can go to the contact sheet that will come to me. And in November and December, if you want to read the book, give us a donation, $50 or more, and let us know whether you want a hardcover or paperback.
Dr. Wendy Dean, thank you so much for joining us on the Visible Voices podcast.
Thank you so much. It's been a pleasure.
The Resa wrap up. Special thanks to Dr. Wendy Dean for joining me in conversation. Audience, 3 take-home points because some of these concepts can be a little difficult to get your head around. Number 1, understanding moral injury. Moral injury occurs when healthcare professionals are forced to act in ways that conflict with their ethical values due to systemic pressures, which lead to deep emotional and psychological distress. This is distinct from burnout. Number 2, the systemic causes and solutions of moral injury. So the root of this moral injury lies in healthcare systems which prioritize profit or bureaucratic procedures over patient care. This often places physicians in untenable situations. The solutions, therefore, must focus on system-level changes, including better alignment between healthcare values and business practices. And finally, advocating for culture change. Addressing moral injury requires a shift in the healthcare culture, where physicians and healthcare workers are empowered to actually voice concerns without fear of retribution. This change necessitates active advocacy from healthcare leaders and policymakers to create, what I'll call psychological safety, which means a sustainable and supportive environment for both patients and practitioners. That's all I have for you this week, audience. See you next time. The Visible Voices podcast amplifies voices in the healthcare, equity, and current trends spaces. We are a production of the People's Media Network. Our team includes Dr. Giuliano DePortu and me, Dr. Resa E. Lewis. Please find me through my website and on social media, Resa E. Lewis, MD, or through the podcast, thevisiblevoicespodcast.com. Please give us a 5-star rating on Apple or wherever you listen to podcasts. Also, please be sure to share the show with a friend. The views and opinions expressed by the host and guests are their own and do not necessarily reflect the opinion of the institution with which they are affiliated or identified. Information herein should never be used as a substitute for clinical judgment or for medical advice.